morning to those in Roanoke and beyond. This is Stuart Schlossman from MS Views and News, and we're starting off pretty much the same way we did last night. I'm wearing this face mask only just so people realize that you should be wearing this when you're out in public, okay? And the reason being is that when I take this off with this bright light in the distance, I can see my spray coming out of my mouth, all right? And if my spray is coming out of my mouth, then anybody that's within 6 feet of me would be catching this. And if I have a virus of any type, well, there's a good chance that you'll wind up with it as well. So we want to make sure that people realize that they should be wearing these face coverings in public. All right? Now, for today's program, we are doing the same program that we did yesterday, that we did last night. Megan Weigel, a nurse practitioner out of Jacksonville, Florida. She's here again to speak with everybody. Yes, we are live. You could see I'm wearing different clothes than last night. All right, and that is a great way of knowing what's going on here this morning. Okay. But for today's event, we want to remind everybody that this program series and this program specifically is sponsored by, we have Sanofi Genzyme, we have Genentech, we have Bristol-Myers Squibb and Novartis, all right, and we want to give them a virtual round of applause. Hey, thank you for doing this for us, all right? Great, thank you. All right, so we have people in Roanoke, Virginia. We were supposed to be in Roanoke. MS Views and News was supposed to be in Roanoke, Virginia, but because of everything that's happening in the world these days, we decided it would be safest if we did not go there, considering that we are primarily from Florida, and we didn't want to bring anything with us to Virginia. All right, so that being said, we're going to get this program started, okay, and I want to tell you all something about Megan. Megan Weigel, a doctor of nurse practitioning, is a nurse practitioner specializing in neurological care in Jacksonville Beach, Florida, where she brings a unique integrative medicine and holistic nursing perspective to her practice. First Coast Integrative Medicine. She earned her doctorate of nursing practice from the University of Florida, where her research emphasis was on preventative health care. Megan is the co-founder of OMS Yoga, a nonprofit organization that brings free yoga classes to people living with multiple sclerosis on the East Coast. Now, virtually, she's actually everywhere, okay? And also, we want to remind everybody, before I have Megan come up, I just want to let everybody know that whoever's watching virtually, you could ask questions online, and we will get to the questions after Megan's presentation. And for those in Roanoke, we're going to be Suzanne will be running around the room, or Sharon will be running around the room, getting you questions and sending them to me by phone like we did last night. Okay? So we hope you have many questions. We will get this program started right now. Let's say hello to Megan. Tap, tap. I got to stay away from her. My face covering is off. Thank you.
Hi, everybody. Good morning. I am in the same clothes as I was last night. But I'm going to use the excuse of I have a 3.5-year-old until he's 18, I think. So, that's just how it is. Thanks for being with us this morning. We've got a meaty talk and then a great time for question and answer. So without further ado, I will get moving. I do want to thank Stuart and MS Views and News and also the MS Alliance. Stuart, MS Alliance of Virginia for helping us make this program virtual. I think that I don't just speak for myself when I say I was a little bit relieved that we weren't traveling, especially with our current environment here in Florida. So what we're going to talk about today is very quickly MS relapses and pseudo-relapses and their treatment, and then we'll move into the current paradigm of disease-modifying therapies that are approved for relapsing and primary progressive forms of MS. We'll talk a little bit about COVID-19, living with MS during this pandemic era, and then the value of integrative medicine in MS care. I say that we'll talk quickly about relapse and pseudo-relapse, mainly because with our current disease-modifying therapies, our more modern disease-modifying therapies, we actually aren't seeing relapses very much. They just work so well. We're also treating multiple sclerosis so much earlier than we used to because of the way that we're able to use MRI to diagnose the disease, the way that our parameters have changed for early diagnosis allow us to treat the disease early. Whereas when I started in MS care as an advanced practice nurse 20 years ago, we used to say, oh, we've got to wait for one more thing to happen before we can actually give you that diagnosis, or one more lesion to happen before we can actually give you that diagnosis. So in any case, we're shutting down MS early, and the future looks very hopeful for people who are diagnosed with MS in today's day and age. Also, we know a lot more about how to treat MS symptoms and what's going on with MS progression. And I feel like learning some things that you can do with your lifestyle for people who are in a more progressive phase is also very helpful and hopeful. So relapses are new neurological symptoms that, or increased severity of old neurological symptoms that last at least 24 and sometimes longer, 48 to 72 hours, and cannot be caused by anything else. And those anything else's are things like infection, significant stressors, lack of sleep, physical exertion, fever. And that brings me to pseudo-relapse. So a pseudo-relapse is an increased severity in a symptom that you've already had or you're used to having. And pseudo-relapses are caused by those other things like infection, fever, physical exertion, exposure to heat, excessive alcohol use, maybe a medication change that's caused a side effect, maybe where you are in your menstrual cycle. Many women have worsening of their symptoms in that PMS phase of their menstrual cycle or during their periods, and fatigue. So an example of a pseudo-relapse would be you're a person living with MS and you're used to having maybe some balance issues and tingling in your hands and feet, and you spend 2 days mostly outside with your family on a camping trip, and suddenly your balance is worse, your tingling is worse, and you're more fatigued than usual. But you don't have any new symptoms. And when you go home and you rest and you get in the cool air, your symptoms go away. So that's how we treat a pseudo-relapse. A relapse, typically, if we put a person in an MRI, we'll have an MRI correlate. So a relapse should be associated with a new gadolinium-enhancing lesion. Sometimes it's not, because the lesion may be too small for us to see. And also, we don't always want to expose, say you have to have an MRI for every relapse that you have, because the exam and the history are really excellent ways to determine whether or not something is a relapse. Typically, we treat relapses with IV steroids, 3 to 5 days, sometimes high-dose oral steroids with a taper. We may also use adrenocorticotropin-releasing hormone, or Acthar gel, which is given as an injection either sub-Q or in the muscle for 5 days in a row. More severe cases may require plasma exchange or IVIG. Plasma exchange is an invasive procedure that requires central line placement. IVIG is an IV medication that's given over 3 to 5 days as well. Pseudo-relapses are treated by treating the underlying problem. So if you have an infection, you're given antibiotics. If you're overtired, you're prescribed rest. You may need to have adjustment of medications to help your symptoms improve. We may recommend cooling equipment or hydration. And for both relapse and pseudo-relapse, we may recommend rehabilitation therapy, like physical or occupational therapy or speech therapy. So let's move on to MS disease-modifying therapies. The treatment landscape, let's call it, has gotten very busy and very crowded in the past 10 years. When I started 20 years ago, I had beta-seron, Avonex, and Copaxone. About 2 years into my career, Rebif was approved. And if someone failed Copaxone, we tried an interferon. If they failed an interferon, we tried Copaxone or a higher dose interferon. Similarly, and then if they failed those, we had nowhere to go until something else was approved. So we're so lucky these days to have all of these medications with different mechanisms of action for which we can use to help slow down and sometimes stabilize the course of multiple sclerosis. I will say that unfortunately, we don't have a biomarker that tells us what the right drug is for each person right now. So we do have to make educated decisions based on what medications you have responded best to in the past when we choose a new medication for you, or have not responded to in the past when we choose a new medication for you. If you're having to make a change because of a disease change, we want to choose a drug with a different mechanism of action than the one that you're using now, for example. There are so many other things that guide our decisions when we choose disease-modifying therapies. And those are the status of your disease. How many relapses have you had? How much MRI change have you had? Have you had mobility or cognitive disability progression? Are your symptoms getting worse? We think about medical comorbidities and past exposure to other immunomodulating or immunosuppressive agents, maybe not just for MS, but also for other autoimmune diseases and perhaps cancer. So those things may take some disease-modifying therapies off the table because there may be contraindications or significant adverse events that might occur. We think about your risk tolerance as a person living with MS and even that of your support team. And what I mean by that is, in my career, I've seen two types of people. One type of person is the person that says, I don't want to try that. Even if that adverse event only happens in one person, I'm going to be the one person. The other type of person is the person that's like, I don't care. I want the strongest and best thing to treat this disease, and I'll hope that that adverse event doesn't happen to me. So we have to think about your risk tolerance. And then on the flip side of the coin, we also have to think about the risk tolerance of the provider. So some neurologists, neurology practitioners, MS practitioners have risk aversion to certain medications because maybe they had one bad experience and they've just decided not to use that drug again. Also, the knowledge of the provider is important. And this is why we talk a lot about the importance of seeing an MS specialist. There are so many drugs in our treatment landscape these days that a person who's a general neurologist in a busy general neurology clinic may not be familiar or may not be comfortable using some of the newer drugs that might be the best decision for you. That doesn't mean that that person's not a good neurologist. It just means that their specialty is not in multiple sclerosis. Similarly, if someone came to me and said, what's new and good in epilepsy, I would say I'm not an epileptologist. Epilepsy is not my specialty. If you really want to get the best and most modern information about that, you should see an epilepsy specialist. So that plays in. Other things that play in are unfortunately your insurance. So some insurances still require step therapy. They still require you to try X before you can get to Y or Z. Financial status comes into play here with commercial plans versus government-based plans and getting patient assistance and whether or not you can afford the drug. Also, your support system. Does your support team, does your support partner agree with your decision for the drug that you chose? Are they going to help you with the things that you need to do to take that drug? What is your willingness to access the healthcare system or other healthcare providers for monitoring? So certain drugs require more frequent lab monitoring. They require other specialists be seen on a regular basis in order to monitor for adverse events. And if you're not a person that wants to do those sorts of things, then we wouldn't put you in a situation where you could be at risk for serious adverse events if you weren't going to follow the directions for taking the medication safely. The route of administration is important. Some people say, I'll never take an IV drug. Some people say, I don't want to take any more pills. Some people say, I'm never going to do an injection. And so when we talk to you about those things, we can take certain drugs off the table. Additionally, transportation and access to care is important, particularly for our infusion-based therapies. So we want to make sure that you're able to get to the medication safely, receive it, and get home safely. So disease-modifying therapies are primarily for relapsing forms of MS. And in fact, as a blanket, the FDA gave all of our current disease-modifying therapies a blanket indication for relapsing forms of MS, including active secondary progressive MS, even if they didn't have particular studies done in active secondary progressive MS. So it's led to a lot of confusion, I believe, for people living with MS, and that's why we really have to look closely at clinical trials and match you up with who you look the most like in a clinical trial when we're choosing a medication for you. In relapsing MS, disease-modifying therapies aim to alter the course of the disease by slowing down relapse rates, slowing down MRI progression, and delaying disability progression. What we aim for is NEDA, or no evidence of disease activity, and that is no evidence of relapse, no evidence of MRI, no evidence of disability progression. There are other categories that we can add on to NEDA, like no evidence of cognitive progression, no evidence of brain atrophy. And I think that when we look at these, the outcomes of these clinical trials, you'll see that none of these drugs 100% reduce relapse rate, 100% shut down MRI, 100% slow down disability progression. And I think it's important to understand that, because if you don't reach NEDA, you shouldn't feel like a failure. Most people reach NEDA at some point in their MS career, in their journey with MS. They may have a 6-month or 12-month or 24-month period of NEDA. They may have a 5-year or a 7-year or a 10-year period of NEDA, and then a change may occur. And it doesn't necessarily mean that you failed. It actually probably means that you outlived the statistics in the clinical trial and your disease was really well controlled. So our goal is NEDA. Because we have so many therapies available now, we may recommend switching more often than we would have 10, 15 years ago when we didn't have as many choices. The first types of therapies I'm going to talk about are our injectable therapies. And this, even this table will change because there's a new injectable therapy that should be approved at some point within the next year that is not first generation and is not old, and certainly is much more of much better efficacy than these drugs. But currently we have first generation injectable therapies that are either interferon, which are betaseron, Extavia, Avonex, and Rebif, and Plegridy, or Copaxone. So first I'll talk about interferons. Interferons work by decreasing T cell activation and proliferation, and they are thought to block T cell migration across the blood-brain barrier, which means that there's less inflammation going on in the central nervous system. By and large, these medications are associated with 30 to 37% reduction in annualized relapse rate. They do a fairly good job of reducing MRI lesions, gadolinium enhancing lesions, and newer enlarging T2 lesions. And they have about 30% relative reduction in disability progression. They are associated with injection site reactions, flu-like symptoms, white blood cell decreases, liver enzyme elevation, and rarely with thyroid issues. So when you're on these drugs, we monitor blood count, metabolic panel, and thyroid function. Glatiramer acetate is a different type of medication. This medication activates Th2 cells, which are anti-inflammatory cells. And as it activates them and they enter the immune system, they release anti-inflammatory cytokines. So it sets up the central nervous system to be anti-inflammatory instead of pro-inflammatory. Copaxone is associated with 34% fewer relapses, 45% reduction in gadolinium-enhancing lesions, and 35% reduction in newer enlarging T2 lesions. The most common side effects are injection site reactions, something called a Copaxone flush, and lipoatrophy, which is like little divots at the injection sites that you've used most frequently. No monitoring is required for Copaxone. And now we're going to move on to our oral medications. This table lists S1P receptor modulators. The the oldest of which is Gilenya, which is the least specific of the S1P receptor modulators. It hits more S1P receptors than Mayzent and Zeposia, which hit S1P1 and 5. In general, what these drugs do is they latch on to this S1P receptor. Because they do this, certain types of lymphocytes or T cells are held into the lymph nodes, and so your circulating immune system has changed. It's not as robust as it was, and that's why it helps MS, because you don't have as many T cells out in the bloodstream to do dirty work, so to speak, against myelin. Monitoring before you start these medications includes always blood count and metabolic panel. I think as a class of drugs, we're all checking JC virus antibody studies. Before you take Gilenya, you need to see an eye doctor and have an EKG, and Gilenya requires first dose observation. While on Gilenya and before you take it, you need to see a dermatologist regularly because of the risk of basal cell and other skin cancers. This is different than Mayzent. So Mayzent does require genotyping before you take the drug. If you have a CYP2C9 star 3 genotype, you cannot take the drug. If you have one star 3, you're required to have a different dose of the drug. And then we do a pre-dose EKG to decide whether or not you need first dose monitoring. The most common side effects of Mayzent are headache, hypertension, lymphopenia, and elevated LFTs, which are a little bit fewer than side effects that we know are associated with Gilenya, which also include PML and CMV meningitis. So cases of PML have yet to be seen with Mayzent and Zeposia. Zeposia is the newest drug to the market. It came out about, I'm going to say 3 or 4 weeks ago. My pandemic timeline is a little bit screwy. Zeposia does not require first dose monitoring. It does not require genotyping. However, we do pre-screening tests similar to that which we do for the other S1P receptor modulators. You can see from the chart here that these drugs reduce annualized relapse rate a little bit more robustly than the injectables do. They do a better job at shutting down MRI. But for the most part, what you'll see on these charts is that what we do the worst is reducing disability progression. So our drugs are best at shutting down inflammation that shuts down relapses, but we're still working with our drugs to slow down, stabilize, or even improve disability progression. Let's move on to the other orals. The first two on this list are forms of fumarate. So we have dimethyl fumarate, which is Tecfidera, and diroximel fumarate, which is Vumerity. It's a different pharmacokinetic of preparation of Tecfidera that was developed to hopefully reduce GI side effects. So these two drugs cause a Th1 to Th2 shift, so pro-inflammatory to anti-inflammatory shift in your T cells. They also cause apoptosis of lymphocytes, and they activate this antioxidant pathway called the NRF2 or the NRF2 pathway. They reduce annualized relapse rate by 44 to 53%, depending on the study you're looking at. Shut down MRI by 71 or 85% in reduction of new or enlarging T2s, and 74 or 90% reduction in gadolinium-enhancing lesions. And there's about a 38% relative reduction in disability progression. GI side effects are most common with these drugs, and this could be anything. It could be an upset stomach, nausea, vomiting, bloating, constipation, weight gain, weight loss, diarrhea. And we try to mitigate those side effects by telling you to take the medication, don't eat the drug. Take the medication with foods that are high in fat. We also recommend aspirin when you first start the medication because of flushing that can happen. And we may recommend GI medications to help mitigate some of those side effects that typically go away after about 6 to 8 weeks. Truly, in the with Vumerity, there are fewer GI side effects. With these medications, we monitor blood count, metabolic panel, and JC virus antibody status. There have been cases of PML with Tecfidera. Teriflunomide or Aubagio is another oral medication that inhibits an enzyme called dihydroxyorotate dehydrogenase. DHODH is the easier way to say it. And this enzyme inhibits rapidly dividing T cells and B cells. So you can think of Aubagio, I like to think of it as two different types of trash men. One is the fast trash man that goes around the neighborhood with the big truck and picks up everything, but he leaves some stuff, like it falls out of the truck. And then you have the slow guy that comes along in the little golf cart and cleans up the mess. So it's the fast guy in the big truck that gets disrupted with Aubagio, but the little guy keeps going to surveil the immune system. This medication reduces the annualized relapse rate by 31%. Between 80 and 84% of people are free from disability progression at 108 weeks. It's associated with 80% fewer gadolinium-enhancing lesions and 68% reduction in total lesion volume. The most common side effects with Aubagio are elevated liver enzymes, hair thinning, nausea, diarrhea, and headache. And we regularly monitor blood count and metabolic panels, specifically LFTs, while you're on this drug. Prior to taking the drug, you need to have a TB test and a pregnancy test. When you take this drug, you need to have liver function testing done every month for 6 months. The newest oral kit on the block is cladribine or Mavenclad. This is given in let's call it a one-time cycle. So you have 2 cycles of the drug that are 4 to 5 days long, and they're about a month apart, and that's it, you're done. The drug, I don't have a dose up there because the drug is weight-based, and so your weight determines whether or not you take it for 4 days or 5 days, and also what dose of the drug that you take. So again, you get, say, time 0, day 1 through 4 or 5, you take the drug, and then about a month later, you take another 4 to 5 days of the drug, and that's it. Mavenclad impairs DNA synthesis in T and B lymphocytes, and therefore this results in their depletion. It's associated with a 58% relative reduction in annualized relapse rate, 33% risk reduction in disability progression, 86% relative reduction in gadolinium-enhancing lesions, and 73% relative reduction in T2s, new or enlarging T2s. Prior to starting the medication, we check blood count, metabolic panel, HIV, Hep C, Hep B, TB testing, and varicella antibody testing. You'll see that with some of our drugs, and I'll go back here to the S1P receptor modulators, we're also checking varicella antibodies. If you do not have antibodies to the chickenpox virus, we recommend vaccination, and that puts off your start date of the drug by 4 to 6 weeks. Mavenclad is associated with lymphopenia, malignancies, infections, liver injury, heart failure, upper respiratory infection, and headache. There are very specific parameters for contraception when you're using Mavenclad. And in fact, I'll just say for all of our drugs, typically we recommend against pregnancy when you're on disease-modifying therapy. We recommend stopping disease-modifying therapy for certain amounts of time before trying to get pregnant, and this is different for each drug. However, what we do know now, because of the length of time that these injectables have been around, is that Copaxone is probably safe during pregnancy. Interferons are now thought to be safe during pregnancy. And some folks are doing extended interval dosing of Tysabri during pregnancy, depending on the severity of the mother or the woman's MS. So let's talk about our IV medications. Our oldest guy is Tysabri or natalizumab. It's given monthly. It's a monoclonal antibody that blocks T cell migration into the central nervous system. And you can think of Tysabri as like Velcro for the blood-brain barrier. That's basically what happens. In relapsing forms of MS, it's associated with a 42% relative risk reduction in disability progression. As you can see from the numbers, it does a good job at shutting down MRI and an excellent job at reducing annualized relapse rate. while you're taking the drug and before you take the drug, we monitor blood count, metabolic panel, and JC virus antibody status. The most serious adverse event associated with Tysabri is PML, or progressive multifocal leukoencephalopathy. We now know what risk factors are for PML depending on what drug you're taking, and I think we feel comfortable advising people about their risk because we have data that goes back 8 to 10 years of and lots of cases to follow to know how people do. Other side effects of Tysabri are infusion reaction, which is really rare, hypersensitivity, elevated liver function tests, and liver injury, and infection, which is not up there, most commonly UTI. Lemtrada is another IV medication, alemtuzumab. This is also a short course therapy. It's given once for 5 days and then a year later for 3 days. Some people do require repeated infusions of Lemtrada over the years, depending on how their disease does. Some people also may transition to other therapies. Lemtrada is a monoclonal antibody directed against CD52, and it reduces circulating T and B cells as well as natural killer cells. The side effects associated with Lemtrada are really directly related to its mechanism of action. So when those new B cells start to repopulate in your immune system, they start to repopulate and may turn on a different system in your body. So whereas they're no longer seeing myelin as something that needs to be attacked, they may look at your thyroid or your kidneys or your platelets. And so Lemtrada is associated with low rates of platelet disorder, autoimmune kidney disease, thyroid disease, and autoimmune thyroid disease, as well as cancers like melanoma, thyroid cancer, cervical cancer. Strokes have been reported, as have liver issues and injury, and infections, particularly viral infection reactivation. While you're on this medication, you have monthly blood count, metabolic panel, urinalysis, and thyroid functions done prior to taking the medication. As you can see with some of our newer and more highly efficacious therapies, we also check for HIV, hepatitis B and C, varicella antibodies. We recommend a dermatology evaluation before and then regularly, as well as a pap smear. Pap smear recommendations may become more frequent for you than they used to be. Lemtrada is associated with a 49% relative reduction in annualized relapse rate versus Rebif, 42% relative reduction in confirmed disability progression, and at year 6, 77% of people on this drug are stable to improved. So that's the language that you're seeing that's new with some of our newer therapies, is that instead of talking about just slowing down disability progression, we're actually talking about disease stability, or in a minority of cases, improvement in disability. Stability is an incredible marker to achieve in MS. Finally, we have Ocrevus given 300 milligrams IV 2 weeks apart, and then from that point forward, 600 milligrams every 6 months. It's a humanized antibody directed against CD20, which causes lysis of B cells. It was also studied versus Rebif with a 46 or 47% relative reduction in annualized relapse rate, 40% risk reduction in 12 and 24-week disability progression, and as you can see, it really shuts down MRI. It's associated with infusion reaction and infection, and its monitoring parameters prior to starting the drug are similar to Lemtrada. While you're on the medication, there is not frequent lab monitoring. That's kind of up to you and your MS provider, but most of us are checking anti-CD20 panels to see what your B cells are doing. Ocrelizumab, or Ocrevus, is also the only therapy that's approved for primary progressive MS. Thus far, it's the only therapy that has shown promise in primary progressive MS. The endpoints for this trial are different than for relapsing trials. For the primary progressive trial, there was a 24% risk reduction in 12-week disability progression versus placebo, and a 25% risk reduction in 20% worsening of timed 25-foot walk. I think it's really important to say that particularly with Lemtrada, Ocrevus, and Mavenclad, because of the way they work in the body, they're considered to be long-term therapies. which means assessing your response to the therapy at 6 months or even a year may not be appropriate. The benefits of the therapy may become most visible or most obvious 2, 3, 4, and 5 years after the therapy has been given. Questions about stem cells are very, very popular. I'm going to make a couple of generalizations based on all of the reading that I've done. As a generalization, best outcomes are seen in highly inflammatory relapsing forms of MS. And as a generalization, best outcomes are seen with higher doses of chemotherapy given prior to stem cell transplantation, but there's also the highest risk in that group of people. So right now, in clinical trials, what we're trying to find is a sweet spot of giving the medication in the most efficacious way with the least harm. Thankfully, there's been a real big pushback for for-profit stem cell clinics, which really were on the rise in our country. You'd go and pay anywhere from $10,000 to $25,000 to these clinics. They would withdraw stem cells and from your from a fatty area, and then inject them back in. There is no data that this works to modify disease. What it does do is throw significant amounts of money into the air and put you at significant health risk. So while I know that it's frustrating because we read about stem cells as really the newest up-and-coming therapy for relapsing forms of MS, we really need to wait until we know the best way to deliver the therapy. So going to a very reputable academic center that does stem cell therapy or considering enrolling in a clinical trial for now is the safest way to get stem cells. The next drug to come out of the pipeline, which I mentioned earlier, is an injectable ofatumumab. It's another anti-CD20 molecule that showed either a 50 or 58% reduction in annualized relapse rate versus teriflunomide. So let's talk about MS in our COVID-19 world. And I have a slide up here about how to correctly use a mask, which means you cover your nose and mouth. Many people have difficulty wearing masks because of claustrophobia and anxiety or chronic lung conditions and trouble breathing. In that case, I recommend a face shield when you're in public places and spaces or in gatherings, which hopefully are not in large gatherings. By and large, the greatest risk of COVID comes from sustained close contact to people who may have been exposed to the virus. There are several studies looking at people living with MS and the coronavirus. One came out of the NYU MS Comprehensive MS Care Center, over 300 people, and basically the conclusions here were that most people living with MS who contracted COVID-19 have not required hospitalization in their cohort despite being on disease-modifying therapies, and disease-modifying therapies did not emerge as a predictor of poor COVID-19 outcome. I'm going to move forward and then back. On the left-hand side of this slide, you'll see a report of an Italian study of over 700 people. And when they looked at their cohort of people living with MS, they found that people who were recently given methylprednisolone or anti-CD20 therapies like ocrelizumab or rituximab had an increased risk of severe COVID-19. Here in the U.S., we have COVI-MS, which is a disease registry where providers can report confirmed or suspected COVID-19 cases. In this study, there are currently 692 confirmed COVID-19 cases. Over 80% of those people are recovering. About 5.8% of those people have died. And of the people who had died, more than half of them had comorbidities. And the most common comorbidities are cardiovascular disease, hypertension, and diabetes. Of the cases of COVID-19, so not the deaths, but the cases, almost half of them had comorbidities, the most common ones being hypertension and obesity. And this brings me to the right-hand side of this slide. When we're looking at coronavirus risk for people living with MS, having MS does not put you at an increased risk of having the coronavirus. What we now believe, based on the data that we have, is that having MS and having these other comorbidities that are associated with higher risk of having the coronavirus are what increase your risk. So it's really the other problems, not MS. So being over 60, being obese, having hypertension, diabetes, chronic lung or kidney disease increases your risk of the coronavirus if you have MS, as it would even if you didn't have MS. Based on the data that we have now, we do think that there is an increased risk for severe illness in people with progressive forms of the disease, as well as people with higher levels of disability, in addition to those things that I've already talked about. And the reason is not necessarily because of the pathophysiology of MS, but because of how your body is functioning. So if you have progressive MS or higher levels of disability, you may be more sedentary, have trouble with breathing, swallowing, clearing secretions, things that increase your risk for infection. We also think that we can talk about certain types of disease-modifying therapy and increasing risk. As a rule, we recommend that healthy people with MS continue to take their disease-modifying therapies during the pandemic. We recommend individualized conversations with healthcare providers if you are on anti-CD20 medications like Ocrevus and Rituxan. We also recommend that at this point, you may have heard things on social media, on the internet, that certain types of disease-modifying therapies like interferons and fingolimod, S1P receptor modulators, may be associated with lower risks of coronavirus and lower risks of severe disease. At this point, we don't have enough evidence to say switch people to those medications to lower your risk of the coronavirus. And we certainly don't have enough evidence to treat you with those medications for the coronavirus. So if you have concerns about the status of your MS, the status of your general health, and how your disease-modifying therapy fits in during this pandemic, I'd encourage you to schedule an appointment to talk to your MS care provider about it. I did a presentation for MS Fusion News, I think it was in early April. It's called Holistic Wellness in Times of Need. I specifically spoke about things that you can do for your mind and your body and your spirit during the COVID-19 pandemic to maintain health and wellness. It's available on the MS Views YouTube channel. I'd encourage you to watch that. It gives information about spices that you can use to cook with, foods you can eat to really increase health in your body. And also there's a specific meditation that helps decrease anxiety. And overall, I'd say that one of the best things that you can do for yourself right now is to limit your news watching, limit your time on social media and the internet. You can pick any rabbit hole to go down and choose anxiety instead of hope. And I'd like to encourage you today to choose hope instead of fear and anxiety. So that brings us to integrative medicine and MS. I practice integrative medicine, which is seen in this red bar here. This is kind of a continuum. So from conventional medicine, which is the way that I was trained, to functional medicine, we kind of move away. We're moving away from conventional medicine. Integrative medicine, though, actually combines conventional and alternative and complementary therapies in a coordinated way. So I don't discard the conventional medical training and nursing training that I've had when I practice integrative medicine. My emphasis is on helping people find modalities that work for them conventionally and also work for them to improve their lifestyle, nutrition, exercise habits, mind, body, and spirit in a way that's evidence-based. So I wouldn't tell you to throw caution to the wind to do something just because one person said you should do it. Integrative medicine does just that. It focuses on the least invasive, least toxic, and least costly methods to help facilitate health by integrating conventional or allopathic and complementary therapies. And these therapies are recommended based on an understanding of physical, emotional, psychological, and spiritual aspects of you. It maintains that healing is always possible, even when a cure is not. So integrative medicine, in my opinion, is a really hopeful place to be. It's a really hopeful hopeful place to practice. I trained under Dr. Andrew Weigel and others at the University of Arizona in a 2.5-year fellowship. And I've found that it has provided me with a really great foundation for moving forward into MS care. So what does it look like in MS care? Well, it looks like me saying, this is the conventional recommendation for you. This is what I think you should do regarding disease-modifying therapy. This is the decision that we come to that's shared. And these are other things that you can do in your life that may improve your symptoms, that may improve your outlook, that may improve your hope, your energy, so on and so forth. And so those things include diet changes, exercise changes. I take a very comprehensive history that looks at social, nutrition, sleep, spirituality, self-care, your medication exposure over your life, your exposure to environmental toxins, things that you put on your body, maybe supplements that you've taken. I do a physical exam, and then based on that, we come up with a plan that works for you. That plan may include labs that you've not had before. It may include referrals to appropriate providers for certain symptoms that you're having. For example, acupuncture, massage therapy, hippotherapy, which is horse therapy, which some of you probably do, even to a licensed dietitian or a nutritionist. I personally I'm not certified or licensed or trained to do acupuncture, so I would refer you to an acupuncturist. That's just an example. And then really clear collaboration and communication with your other healthcare providers, because I want people to understand the benefits of integrative medicine and not see it as something that's woo-woo, so to speak. I want my colleagues to see it as something that's valuable. I've got a few minutes here, so I'm going to cruise through these slides pretty quickly and just give you bullet points about each of these components of integrative medicine. So nutrition, people ask me all the time, what's the best diet for people living with MS? There are several that have been studied. The Walls Protocol, the Swank diet, the Gold Coast Cure. Now we're talking about the ketogenic diet, intermittent fasting. My basic rule is eat food, not too much, mostly plants. This is really important. Nutrition is really important in MS because people living with MS have a higher risk of vascular comorbidities, and this increases your risk for disability. When you have just one vascular comorbidity like diabetes, obesity, hypertension, or high cholesterol, your risk of reaching an EDSS of 6 is faster. So what can you do? Rules to live by. Reduce your consumption of processed foods, eliminate sugar-sweetened beverages, eat a colorful plant-based diet, and if you eat meat, eat it as a condiment, not as the center of your plate. Reduce your consumption of alcohol. You guys, I don't know what's happening in your community, but in mine, I have seen alcohol use significantly increase during the pandemic, probably reasons are manyfold. One of the reasons being anxiety over finances, job loss, change, and another one being boredom. So please be careful with alcohol use. Many people ask about buying organic foods. I refer people to the EWG Environmental Working Group's website. It's ewg.org. Every year they put out 2 lists. One is the Clean 15, so those are fruits and vegetables that you don't have to buy organic. The other one is the Dirty Dozen, and those are fruits and vegetables that you should always buy organic. And if you focus on those lists, you should be able to save money instead of buying everything organic. Eat your omega-3s, eat your nutrients, eat your prebiotics and probiotics. You don't necessarily need to be taking 1 million supplements a day. And stop eating processed meats. With the rise of the ketogenic diet, I think it's given many people license to eat a lot of processed meat products. These are salted, cured, fermented, smoked meats, deli meats, hot dogs, bacon, all of these things. And these things are actually found to be grade 1 carcinogens according to the World Health Organization, which also cigarettes are. So talking about movement, I'd like to reframe how you think about exercise. And instead of thinking about exercise, which can cause you to just feel like a failure from the beginning because maybe you can't exercise like you used to, think about moving your body every day. Are you willing to change your idea of exercise to one of moving your body every day? And then what can you do to move your body that you enjoy doing, and do just that? Do it for 150 minutes a week. That's about 22 minutes each day. And know that exercise is associated with all of these benefits: decreased weakness and fatigue, better mood, improvement in bowel or bladder function. You might ask, well, what can I do? I can't go to classes. I can't go to the gym. There are so many virtual exercise programs available. They're specifically for people with MS. There's MS Workouts, there's My MS Gym, there's Dr. Gretchen Hawley's exercise program, and she, I know, has done several talks for MS Views and News, so you can find her on the YouTube channel as well. There's OMS Yoga, omsyoga.org. We offer 4 free yoga classes to people living with MS weekly virtually, and there's also yogamovesms.org, also offering virtual yoga classes. So fortunately, COVID-19 happened, and many of us were forced to get our programs online, and we've been able to access so many more people. Our communities have expanded, and it's awesome. So I'd encourage you to check out online programs. Sleep, really important, because as you guys know, fatigue is the most worrisome, frustrating symptom of living with MS for many people. But MS may not be the sole cause of your fatigue. Sleep disorders are associated with MS. Anxiety and depression can mess with your sleep. Medications can mess with your sleep. Other medical conditions can mess with your sleep. So if you're having problems sleeping, it's really important that you talk to your healthcare provider about it. I've outlined some good sleep hygiene practices here. Maintaining a regular sleep-wake schedule is important. Developing a relaxing evening ritual instead of watching the news. I'll say that again, turn off the news at night. Is really important for sleep. Avoid caffeine, sugary foods, alcohol before bed. Keep your bedroom cool. Reserve it for sleeping and sex. Don't use it for work. Don't use it for your virtual classroom, for your children. Make it a sacred space for you. If you do use a device to read, like a Kindle or an iPad or something like that, use blue light blocking lenses or get a blue light blocking screen. And practice, instead of trying to fall asleep, practice letting go of waking. So it actually is just a mind shift that allows your body and your mind to relax. That brings us finally to mindfulness. So what is mindfulness? Well, mindfulness is the woman on the right, not the woman on the left. Mindfulness is being 100% present wherever you are. And why is that important? Well, our stress levels these days are so high. For many of us, myself included, it took me several weeks to relax into what I considered to be a gift. And that was that my schedule changed. My commitments rapidly came to a halt. And as a person who's always on the go, I had a really hard time with that. It took me about, honestly, 6 weeks to settle into that. And when I finally settled into that, I found myself at the top of this chart, like peak performance. I was focused, I was healthy, I was energized, and then suddenly I was tired. And I had to use mindfulness practices to change that mindset and go from the woman on the left to the woman on the right. Stress management techniques include following a healthy diet, exercising and getting adequate sleep, and then mind-body practices. So these are things like counseling, journaling, using apps for meditation, using a regular spiritual practice, finding community and friends or MS support groups or church, even though right now we know that for most people is online. I'll also throw out a resource here for you for guided imagery, which is a lovely way to enter into a mindfulness practice if you have a hard time quieting your mind. Guided imagery is similar to guided meditation, but it is a different practice. The best resource I found for free guided imagery is Kaiser. So Kaiser Permanente is the big healthcare system on the West Coast. It's spelled Kaiser. And if you simply Google Kaiser podcasts, the first or second link that comes up, click on it and you'll find a list of free podcasts for every mental state and physical condition that you could possibly imagine. Take a listen to those and find some peace. Lastly, I'm just going to say a few words about supplements. I believe that our bodies were meant to heal with food. Most studies that talk about supplements in isolation find that eating the food is better than taking the supplement. And you can think of supplementation as eating mass quantities of certain foods in isolation. So let's say you hear that blackberries are good for you, so you're just going to eat blackberries all day for a week. Well, guess what would happen? You'd probably end up with diarrhea. You'd certainly miss out on protein and fat. You'd be tired. So you can see where I'm going here. The supplement industry, the nutraceutical industry, in my personal opinion, has left many people to believe that they need certain things to be healthy and well, whereas I believe that major changes in your lifestyle, and major doesn't have to be hard, just major changes in your lifestyle can improve your health and wellness. This is an algorithm that I suggest that takes a look at evidence for helpfulness of an MS symptom, and then also evidence for harm. And I consider financial harm to be part of that. Many supplements are upwards of $60 per month. And if there's not evidence that they're going to help you, can you really afford to spend $60 a month on something extra? And there may be evidence that something else would help you better. So I go through this when people come to me with questions. Whew, I need a breath. I need some mindfulness. So with that, I'm going to turn the mic over to Stu, and I just would like to say that there is so much anxiety in our world right now, and it ranges from COVID-19 to politics to vaccines to conspiracy theory. Pick your rabbit hole. I have chosen in my life not to go down those rabbit holes. I've learned how to protect my psychological space, my mental space, my spiritual space from things that cause me anxiety and ultimately affect my health. And I've chosen instead to live for the moments that you can't put into words. And I'd encourage you guys to do the same. Thanks.
Woohoo! Megan, round of applause. Awesome. Thank you for all that. That was a great presentation. You were very relaxed. You should be running for president. It was unbelievable up there. Yeah, right.
Will you be my campaign manager?
I can be. So we have a lot of questions that have come through online. Previously, those that pre-registered. Texting from Roanoke, so we made it a little bit easier. Instead of me being on the phone with them in Roanoke, they are texting in the questions now.
That's good.
Right, exactly. And so one of the first things that we got from online, pre-questioned, and from Roanoke is they want to know, again, they didn't hear you correctly, or they did hear you, but not everybody, in Roanoke about OMS yoga. So if you could say something about it again, and when is the next online class?
Sure. So OMS yoga classes, if you go to omsyoga.org, click on live stream, it's the far right tab, and there are directions with how to register. It takes you to another website that we use for registering and filling out an online waiver. Classes are now going on a 6-week on, 2-week off schedule. So you can scroll through the weeks by week. If you don't see a class there, it's because it's not offered that week. You can register for every class that you want to attend all the way out through January. I've built the schedule out through January. Currently, we offer a Sunday 2 p.m. chair class, a Monday 11 a.m. yoga flow with chair modifications, a Monday 7:15 p.m. breathing and meditation class. It's about 15 minutes, and a Wednesday night yoga flow that is adaptable at 5:30. Another great yoga resource is Yoga Moves MS. That's yoga, MOVES, MS.org. And they offer online classes as well as online waivers as well.
Great, thank you. So let's start off from Roanoke, since this program was supposed to be there this weekend. And the first question is, how do the DMTs affect teeth or gum health? Is there any question
that's
about
an
that?
Interesting question. I would say that, with our disease-modifying therapies that are more B and T cell depleting or suppressing, You could also be, and I'm just theorizing here, I will tell you right off the bat, there is no data on this, but there is an upwelling of data on oral health in general. So your body is a home for good bacteria, and if you lose good bacteria, then you can have an overgrowth of bad bacteria. So I think that when your immune system is compromised or modulated or suppressed, oral health is incredibly important, because we also know that poor oral health is associated with cerebrovascular disease. So when you're on a disease-modifying therapy, I guess, my advice would be to make sure you're seeing your dentist at least every 6 months, if not more frequently, if they recommend it. Make sure you're flossing every day. And, I'll go back to those diet recommendations. Eliminate or decrease processed foods and sugar-sweetened beverages, processed sugars.
Okay, thank you. So speaking of diet, a person asks, if there is a concern for sufficient protein on a plant-based diet, especially for a very active person.
Yeah, that's probably the most common question asked of people who are thinking about following a plant-based diet. So a plant-based diet simply means that your plate is most full of things that grow out of the ground versus things that have moms. That's the way I look at it. And many people who are following a plant-based diet, if they're eating animal protein or mostly eating fish protein, that's a generalization. As a rule, following a vegetarian or a vegan diet that is well balanced with healthy fats will provide you with an adequate amount of protein. A great website that I like to follow is... Oh, goodness. Well, it's the McDougall diet, McDougall. They provide excellent resources for getting good protein from plant-based sources. Grains are very high in protein. If you're eating just a few things every day because that's all you know to do, then you would be at risk for protein deficiency. But if you're eating a balanced plant-based diet, then you're not.
Great, thank you. And adding to that, a person asks if he or she does not like eating fish, is there a specific fish oil by brand that you might be able to recommend?
Yeah, so by brand, off the top of my head, I know that several companies make literally a no fishy burp fish oil. I believe that Nordic Naturals makes one, and they're one of my favorite brands. There are also omega-3 supplements that are made from algae instead of fish. And so if you are just for ethical reasons don't want to eat fish versus I don't like fish, then you can get an omega-3 supplement that is algae based, or increase the use of flax and chia seed in your diet and nuts.
Thank you for that. Now, a person who is a carnivore, a meat eater, and that wants to switch to a plant-based diet, is there any recommendation you can make for how quick they should switch over?
I mean, I think that's really up to you and your psychology. Do you do better stopping things cold turkey, or do you do better easing into it? I would certainly arm yourself with resources. Again, that if you Google McDougall diet, you'll find some great resources. There are camps actually that you can attend that are plant-based, and McDougall has some of those. I would encourage you to watch a movie like Forks Over Knives is a really good one. There are great plant-based cookbooks that you can buy on drandrewweil.com. There are recipes and lots of information about an anti-inflammatory diet, which is a Mediterranean type diet. So I think it just depends on how quickly you want to give up what you're eating. And again, a plant-based diet is not a vegetarian diet. It just means you're cutting down the amount of animal protein you're eating.
True. Thank you. So switching tables slightly or greatly on food, a person wants to know what the benefits are of dark chocolate?
Oh, I love that question. It's good. I eat it every day. So the benefits of dark chocolate, and dark chocolate, if you're going to eat it for its benefits, it needs to be at least 70% cacao. That's dark. The benefits of dark chocolate are found in its antioxidant profile. Keep in mind that it's to be eaten in moderation. So it's also lower in sugar than milk chocolate, and because let's say the bean is more whole, so it's not as processed. So our bodies are able to use the antioxidant benefits of that bean better than with milk chocolate. I personally, because it's so rich, will have a square or two at bedtime, and I'm not at bedtime, but after dinner, and I'm done. Whereas if I'm going to eat M&Ms, they're going to keep going into my mouth because there's got to be some addictive property in that sugar, right? I think we all know that.
So before we get to the next question, well, it's a question also, but this person would like to know, will some of the sites that you talk about be listed on the MSView site? Is there a way that you could give me a list of all of everything and we could post it up there?
Sure. I'll direct you, not the nutrition sites, but the exercise websites that I talked about are all in this presentation. So if you go to the Holistic Wellness in Times of Need, I've listed all of the websites for exercise. I'm happy to provide Stuart with a list of the diet nutrition sites.
And with what Megan just mentioned, that specific program that we did with Megan back in, I think it was the beginning of April.
Yeah.
It is shown on our YouTube channel. So for whoever doesn't know how to get to the YouTube channel, just go to our website and click on where it says YouTube. Then go there and type in the search box, Holistic Wellness, and boom, it'll open up for you.
Yeah.
Okay? And if you can't find it that way, then just send an email to me and I'll direct you there. Okay, continuing with the next question. On most MS blogs, everybody talks about supplements, vitamins, bee stings, and excrement of larvae, hookworms, etc. Is there a list of which vitamins and supplements are most beneficial? And this person spends about $100 a month on supplements and vitamins and just wants to know what better can come of it.
Yeah, I would recommend that you meet with a knowledgeable integrative medicine provider in your area and try to reduce your list. The most important supplement for multiple sclerosis is vitamin D3. You should have your level checked, your vitamin D25OH level checked before you start taking vitamin D3 so that you know how much to take. And you also need to be sure that you have good liver and kidney function in order to metabolize the vitamin D. Other supplements that actually have data in multiple sclerosis include alpha lipoic acid, which is being studied in secondary progressive MS. Some folks take biotin, which was a real big buzz maybe about 5 years ago. High-dose biotin looked like was favorable in slowing down progression in secondary progressive MS, and then another study came out that showed those people that were followed had actually an increase in MRI lesions. So I think the jury's still a little bit out on biotin. But then if you think about MS symptoms, there are many MS symptoms that could be helped by supplements if you have nutritional deficiencies. So a good evaluation of your vitamin and mineral status, I think, is important before you just start piling on supplements, because I'll tell you, there's not much scientific evidence for many supplements. And like I said, you want to be sure that there's evidence for what you're taking and that there's minimal evidence for harm, and that includes financial harm.
Okay, thank you. Person writes, how do you get a mountain man to calm down and do yoga? Is there a magic word? I know it sounds silly, but it's real. All these tense people out here just won't change their ways. Is there something you can recommend?
Yeah, go.
Go.
Just attend a class. I've been teaching yoga for 8 years. I've been teaching MS yoga for, I think, about 8 years, 7 or 8 years. And in our classes, I can tell you it took 2 years for some people to close their eyes in Savasana, which is the pose at the end where you're supposed to be relaxed. 2 years. And that's just not in MS yoga. It's in yoga classes in general. People can't calm their eyes down. They're looking around. They don't trust. They don't feel safe. I would say just attend a class. Yoga is a practice. It's going to be different every time. But you get a benefit just from being there and being in community with other people. And that goes even for our virtual classes. Our virtual classes, we now have yogis living with MS from Canada to Puerto Rico on our class. And we chit chat and we have a great time. And so I would just say show up. It'll sink in eventually.
Great. And for those who have MS questions, we are going to get to them in a minute. I just wanted to get past all these complementary type of questions first. But another one is, can you use meditation like as a step between the tense life and then getting into yoga, just so they can learn to chill out a little bit first?
I mean, yoga is a moving meditation. Walking is a moving meditation. You can actually find on YouTube walking meditations that you can listen to. If you want to just start doing guided meditation, I recommend the apps Insight Timer, Oak, O-A-K, and Calm. And most of these apps are free right now because of the pandemic. Also, Headspace is a good one. And they have guided meditations that are short, and they're a good way to get introduced to meditation.
Great. Thank you very much. What, if anything, would be good for exhaustion and body aches?
So first of all, if you have fatigue and body aches and you live with MS, we need to make sure that it's due to MS. So we need to make sure that your kidneys are working properly, your liver's working properly, your electrolytes are within normal range, your vitamin B status is normal, your thyroid is functioning properly. If all of those things are good, you don't have problems there, and you don't have issues with depression or sleep, then we can move on to, this is MS, what can we do about it? We use several medications to treat fatigue in people living with MS. Off-label, we use things like modafinil and desmodafinil, which are Provigil and Nuvigil. Some people use amphetamines like Adderall. Some people use antidepressants like bupropion or Wellbutrin because they're stimulating. And also dalfampridine or Ampera is used to improve walking speed in people with MS, and I think most people would say at the end of the day they feel that they have a little bit more energy when they take that medication. I would also prescribe exercise without a doubt because exercise improves fatigue in people living with MS. It also improves pain. So I would definitely use those things. As far as body aches go, we need to make sure, again, that it's not something else. I could go on and on with a list in my head here, but if it's aching related to MS, you may benefit from massage, you may benefit from physical therapy, you may benefit from certain supplements that can help with inflammation depending on what other medications that you take, or you may need pain medication.
Great, thank you. Going back to Roanoke, question is, just how do you think the future looks for our children being homeschooled by people that really don't have the education to teach their children, or the way some of the home lifestyles are, with people being over abusers of maybe alcohol in these areas or whatnot?
Yeah, I mean, that's really outside of the scope of this talk. If you just want to know my opinion is that I worry about our kids. I worry about even kids that are going back to school and then somebody gets a positive COVID test and then the school has to shut down and so on and so forth. I worry about the mental health of our country in general. Even before COVID, I feel like it was going down the toilet. And so what I've chosen to do, as I alluded to earlier, is not go down rabbit holes that only serve to increase my level of anxiety. So I could sit up at night and never think about and never sleep if I chose, who made the COVID virus? Is the vaccine a conspiracy theory? are masks a conspiracy theory? I might never sleep. So what I've chosen to do is figure out in my house what's going to work best for the sanity of myself, my husband, and my child, and then do the same thing with my family and my friends in my neighborhood, like reaching out and saying, how can I help you? What can we do for each other, so that we can strengthen our communities. I think that the health of our nation starts in our communities, and that has to first start in the home. So I don't know if that really answered your question, but that's my opinion. I think it's something that's of concern and will be studied and watched and talked about.
Okay, great. Thank you. We have a lot of MS questions to ask.
Yeah.
Okay, I know that you're on a time crunch, so you may want to do a lot of yeses and nos or something. The first question is, do you have any suggestions for bladder issues?
Yes. Next question. I'm just kidding. So lots of suggestions for bladder issues. There are 3 types of bladder dysfunction in MS. It's important to know which one you have because that influences the recommendations and the medications. If you've never seen a urologist, I would recommend that you do that. Primarily with bladder issues, it's important to stay well hydrated. It's important to minimize caffeine and alcohol use, minimize the use of sugar and artificial sweeteners, spicy foods, citrus foods. Doing all of those things can help calm your bladder, and you may not even need to go see someone. Also, make sure you're eating a well-balanced diet that's high in fiber so you don't stay constipated, because if you're constipated, it pushes on your bladder, increases the risk of incontinence, urinary tract infection, and that was the rest of my yes.
Great. Thank you. All right. What treatment options are available when you may no longer have relapse-remitting multiple sclerosis and may have moved quietly to secondary progressive?
So, as I mentioned earlier in the talk, all of our disease-modifying therapies now have an indication for active secondary progressive MS. However, they weren't all studied for that. The drug that was studied in an active secondary progressive population was siponimod or Mayzent. So the average age in this clinical trial was like 48 instead of 38. The average EDSS score was much higher than 2.5. It was more like 5. The average time of having MS was like 15 years instead of 2 to 7. So if you have active secondary progressive MS, which means you're still having relapses within a couple of years, or you've had MRI changes within a couple of years, you may want to talk to your MS provider about whether or not Mayzent would be appropriate for you. If it's not appropriate for you, then my focus would really be diving deep into your lifestyle and what changes you could make with nutrition, exercise, and mind and spirituality that might help improve the way you're feeling.
Thank you. What opinion of HSCT do you have for a primary progressive?
So as I mentioned in the talk, the most benefit for HSCT is for highly inflammatory relapsing forms of MS. So in general, when I talk to people living with primary progressive MS, I'm not talking about HSCT because the risk may outweigh the benefit at this point in time. And again, it really depends on what your primary progressive MS is doing, how fast is it progressing, are you having MRI changes? If that were the case, if you had highly inflammatory MRI, then it may be worth a discussion.
Thank you. Mm-hmm. Next one. Under what circumstances can DMTs alleviate symptoms?
So I would, disease-modifying therapies aren't meant to alleviate symptoms, but just by the nature of their mechanisms of action and calming down inflammation, they may alleviate some symptoms. They certainly may alleviate future symptoms that you didn't know you were going to have by decreasing relapse rate. Some of the disease-modifying therapies have done post-marketing studies, and they've found that long-term use of them has been associated with better fatigue, better cognition. Some people have improvement in mobility. But if you're looking for I think what's most frustrating for people is they say, well, I'm taking my medicine, I'm doing everything that you told me, I'm taking my disease-modifying therapy, and I'm still tired, or I'm still tingly. And unfortunately, we know that the disease-modifying therapies probably aren't going to help with that. We need to move to symptomatic treatment of those things.
Okay, thank you for that. Person writes, what's next after Lemtrada? I'm JC positive with a very high titer. Not interested in a treatment that has a risk of PML. I've already done a third round of Lemtrada. What's next for me?
Depending on what else you've taken, you could, some people go from Lemtrada to Copaxone, actually, or Lemtrada to interferons. Some people go from Lemtrada to ocrelizumab. So there are things that could be next for you. It just depends on your risk tolerance as a whole, because PML might not be the only problem.
For a family member of somebody with multiple sclerosis, the family wants to know what more they can do to help the MS patient out.
Well, that's a great question. So support partners, your support team also needs support. So what else can you do? You can come to more programs like this. You can engage in other programs that are built for support partners. I'd encourage people to take a look at Can Do MS, which is another patient advocacy organization. They put together excellent webinars and virtual programs for support partners, so that's a really good resource. I would take a look at those resources.
Thank you. Are you aware of any integrative medicine practitioners in the Nashville, Tennessee area?
I am not, but you can go to, I'll give you two websites. One is the Andrew Weigel, that's W-E-I-L, Andrew Weigel Center for Integrative Medicine, awcim.org, I believe, and there's a Find a Practitioner search. Also, the Institute for Functional Medicine, which is ifm.org, there's a Find a Practitioner search. On IFM, you'll find practitioners running the gamut of like health coaches, chiropractors, everything in between. I tend to recommend that people stick with physicians, MDs, DOs, NPs, and PAs, particularly when you have a significant medical comorbidity like multiple sclerosis, because they will have more knowledge of your medications.
Great, thank you. There are some new people that have come in to the question that were not on during the program, and I just want to let you know that you are seeing Megan Weigel. Okay, she is our presenter for this weekend. All right, and I am Stuart Schlossman, president and founder of MS Views. And if you have any questions, please just type them in the box that you're working from, or that you're seeing on the right side of your screen. All right, and we could go forward from there. Megan has answered and done a fantastic presentation last night and this morning. And if you missed it, you can always watch it later on our YouTube channel. It could be a week, it could be a few days, it could be 2 weeks before I get it posted, okay? But you will be able to catch it again. All right, so our next question, though, is what is the best exercise or treatment for chronic tightness that progresses so intense squeezing around the torso with all activities that they do?
So I would definitely be involved in some sort of stretching exercise, and I would do that under the guidance of a physical therapist who has knowledge about multiple sclerosis. I would also recommend body work with a good neuromuscular or myofascial massage therapist.
Thank you. Can you tell us about the gripping feeling felt in the chest? She or he would like to know if this is any similarity to what they've heard of concerning the MS hug.
So an MS hug is usually described as like a tight squeezing feeling around your chest or torso. It can just be on one side. Sometimes it's all the way around. If you're having a gripping, squeezing feeling in the center of your chest or on the left side of your chest, I would say that's an emergency and you should call 911.
Absolutely, absolutely. What do you feel might be the best exercise for spasticity?
Spasticity is an outcome measure for most exercise studies in MS. Most exercise studies in MS run the gamut of walking programs, directed strength training programs, Tai Chi, Qigong, yoga, swimming, dance. Most of these exercise modalities help improve spasticity. So I would pick one of those that works the best for you and do that. And that you enjoy. Start there.
Thank you. All right. There are a few COVID questions. We will get to them later on. It's not that much later on. We're getting to that point already. But is there anything currently, though, going back to the other questions, is there anything in the pipeline for myelin repair?
Yeah, so if I close my eyes and remember a presentation I watched just this week, there are about 20 drugs that are being studied for remyelination and neuroprotection. Some of them are already being used in MS. Some of them are drugs for other disease conditions. Some are just names and letters and numbers. But most of them are in phase 1 study, which means they're in safety study. A few are in phase 2. So it's going to be a few years before we know the answers to those things.
Thank you. How close are we to a biomarker for a drug choice that can be used?
Well, goodness. So, neurofilament light, or NFL, is a buzzword because it's something that we can measure in the spinal fluid and serum now that helps us determine it may help determine disease severity, so we can predict whether a person is having inflammatory activity in the brain. Instead of doing an MRI, we can check this. As far as a biomarker for a specific drug, I don't know. I really don't know how close we are, to be honest. I just read an article about looking at people who have certain HLA genotypes and actually risk for COVID. We're learning more and more every day. But short of pharmacokinetics, like with Mayzent or Saponapod, and knowing that if you have 2 copies of the STAR3 gene and CYP2C9 STAR3, you can't take the drug, I'm not sure how close we are to knowing that just yet.
Okay, great. Thank you. Okay, the next one is, you said something earlier about show promise as a reaction to MS disease modifiers. Does this mean does this mean elimination of disease or a slower progression?
Okay, so I think what someone's referring to is I was talking about disease stability. So today, with diagnosing MS earlier than we could 20, even 10 years ago, and getting a person started on a highly effective disease-modifying therapy right away, what we're seeing over time is disease stability instead of slowing down of disease progression. And within that disease stability, with certain medications like ocrelizumab, alemtuzumab, we are seeing some improvement for periods of time.
Okay, thank you. All right, next question, MS related. Are you aware of any study? That was not it, sorry. Yes, are you aware of any study to treat PML so patients who were successfully taking Tysabri can go back on their miracle drug?
Assuming they've had PML?
Well, if they had PML, I guess they'd be in big trouble. So let's go with maybe there's a study for people that have been tested positive for JC?
So what we know about PML is that if you're JC virus positive, the higher the number of copies of antibodies that you have, the greater your risk is for PML. And there are parameters for that, as is your age and your prior use of other immunosuppressive drugs. So I think the answer is that's really a conversation that you need to have with your MS provider. I have, over the course of my career, left people on Tysabri with high titers of JC virus antibodies and increase the frequency of MRI so that we could look for early PML. And we have a really high level risk discussion with each appointment. We see them more frequently. So I don't necessarily think that is a no-go, so to speak. It may be a no-go for your physician, but it may not be a no-go for another MS care provider. It's certainly something that needs to be undertaken with an understanding of risk.
Do you know if there's a treatment for PML?
There are many drugs that are used to treat PML. There's not one specific drug that's used. Most people with PML have minimal disability. Some people have moderate disability, and as we all know, some people die. But I think the medication given depends on what's going on in the brain, what happens when you have to stop the Tysabri and you wash out the Tysabri is this immune reconstitution syndrome, which causes problems. So it's a pretty complicated condition to treat.
Thank you. All right. So like this event being a hybrid program, I have a hybrid question to ask you between COVID and multiple sclerosis.
Okay.
Many people think and by the way, this is from Roanoke, so if it's really long-winded, I exactly know where it came from. Many people think their MS is getting worse, yet it's obvious in most cases it's COVID stress. We can't get in with our doctors in Roanoke. We have a serious doc shortage. New diagnosed or unsure and an experienced older person can see that they are just stressing but don't want to act like we are the doc, but want to help each other. Can you maybe enlighten people how to separate an exacerbation from stress?
Yeah, so let me just go back to this pseudo-relapse slide. So if you're under significant stress, your MS symptoms could get worse. And it's important to understand that they're not the stress isn't necessarily causing inflammation in your brain, but the psychological stress of your body is affecting the physiology of your body. So if you tend to have spasticity, your spasticity is worse. If you tend to tingle, your tingling's worse. If you're tired, your fatigue is worse. Now, long-term significant stress is associated with MRI changes and relapse. So I would really encourage people to get a handle on what they're doing to manage their stress. And this goes back to using virtual resources for mindfulness, meditation. We have OMS Yoga as a really excellent 15-minute breathing class every Monday night that you could jump into. I'd also encourage you, like I mentioned before, to check out some of the can-do resources that are available online and up and coming to help manage stress.
So the person, I hate to embarrass her, but the person that asked that question that I said I knew who it was going to be because it was very long-winded, just sent me a picture of herself, giving me a funny face. Yes. So thank you, Suzanne. We appreciate your question. All right. Next, we got a few COVID-related questions. One being that they hear so much positives and negatives about this one drug with the H word, hydroxychloroquine, which, by the way, when this thing first started being said, I was like, hi who? Hydroxy what? But now it's being said so much, you could just like let it roll off your tongue. So what can you tell us about hydroxychloroquine and what they're actually finding or not finding about this medication?
Yeah, so what they've inevitably found about hydroxychloroquine is that it doesn't do a great job at treating COVID. It's bottom line.
Thank you. Mm-hmm. Blood type and susceptibility to COVID-19. Is anybody more prone to it than another?
My best friend told me, literally, because I haven't had time to look this up, my best friend told me that because she's O positive, she's less likely to get COVID. I Googled it real quick and I found a small study. I honestly, I hate to say this, I really don't have time for this stuff. So I've got to like really focus where I put my research, and I would never say to a person with O positive blood, don't wear a mask, don't wash your hands, go breathe on 100,000 people at a concert, you know? So I think that, you know, if it eases your anxiety to know that, then certainly let it ease your anxiety, but you still need to follow the same precautions that we all do.
Next question, and thank you for that honest answer.
Sorry to be so honest.
No, that's great. I mean, that's what we want. We don't want people making things up, you know, especially during these programs. It's always best to hear your opinion, all right? And that comes with a major disclaimer too, right?
Right.
Okay, so with the virus, this person wants to know, should I take an MS drug? I've never been on any since diagnosed in 1996.
Do you need an MS drug if you've not been on one since 1996? Is your doctor recommending that you take one now? If so, why? I wouldn't take one just because of COVID, because they don't help with COVID. I don't know. I'm hoping that answers the question, but
I don't know, and I don't know how you could answer this next one either. But
Great.
a person
These are
wants to know.
great.
A person wants to know if you know if coronavirus is man-made or what's the root of this thing?
So I don't know. A few minutes ago, I talked about the rabbit holes that you could go down if you want to worsen your mental health and increase your anxiety. That's one of them. I choose not to go down that rabbit hole.
All right. Last question that people are asking, and if you hear me a little muffled right now, it's because I have my mask back on because I'm coming back out in public, all right? And I'll do that in a minute. So, firstly, we want to thank Megan
Thank you,
very
guys.
much. She took her weekend to be here with us to do this in Central Florida, okay? And we're getting a lot of questions since we started it last night. How did people contact you at First Coast?
So I would recommend that you go to my website, which is, I'll just pull this down real quick. It's First Coast, FIRST COAST, Integrative, so INTEGRETA. Oh my God, I can't even spell this morning. Integrative, First Coast Integrative Medicine.com, INTEGRATIVE medicine.com. The first thing that pops up is like an email contact, and you can subscribe to that, send me a question. My email address is on there, and that's really the easiest way to get a hold of me. I'd love to hear from people.
Great. Thank
Yeah.
you very much. Again, we want to thank Megan. Yay! Everybody say thank you.
guys.
Clap your hands wherever you are, and we'll know you did this virtually, okay? This was an MS Views and News program. I did offer something for the people in Roanoke. I offered the people in Roanoke that somebody's going to win a door prize. We have to say door prize in Roanoke in Virginia because raffles are illegal.
Oh, wow.
Okay, it's like betting, you know,
How
so you can't do
exciting.
that, right? So we do have a door prize, but I'm going to do that after the program ends because we realize even though I wanted to do it online, we have 40 tickets and we have less than 40 people in attendance there. So we can't quite do it like that, all right? So we'll have to I'll get on the phone with you guys afterwards. We'll call it out and we'll have to do it that way, all right, guys in Roanoke? We'll be back with you. All right, meanwhile, again, I want to thank our supporters of today's program, all right? We have Novartis and Bristol-Myers, we have Genentech, and we have Sanofi Genzyme, and we should all give them thanks for they having us do this program, okay? So we have to be careful. And remember, for those that weren't on the program at the beginning, when I'm speaking with my mask off, in the view, in this bright light, I could see the spray coming out, all right? And I will say this time and time again, that is what we are protecting those around us. This mask is not to protect me. This mask is for me to protect you from me. Not that I have a virus, but somebody might, all right? And you want to make sure that if you're in vicinity of anybody, that they are wearing a mask, all right? They have to be wearing something to protect what you might be getting on your face, in your eyes, getting into your body. All right? You must protect yourself, and the only way to really do that is to make sure people around you are wearing a face covering or you're standing a good 10 feet away. And if you're standing 10 feet away, don't be standing downwind of a breeze either, because that's just going to carry. All right? Yes?
Yes.
Great. See, I'm right. Okay, cool. Anyway, let's again say thank you to Megan. She's got to get on the road.
Thank
we
you,
have
guys.
to all get on the road. We might have a storm coming still, so we'll have to see what's going on, okay? Thank you, everybody, for coming on.
Have a great week, you guys. Thanks.
Thank you.
Yeah.
Great. Thank you.